to thank the Chandra Center for inviting me to Bangalore. I bring you greetings on this sunny day from New Delhi, and mercifully we did not have any fog at the New Delhi airport, and it was indeed very pleasant to come to the spanking new airport at Bangalore. My brief this afternoon is to talk about atherosclerosis and rheumatic diseases, the new age diabetes. Now, if you look at autoimmune rheumatic diseases, joint pains dominate the clinical picture. These are multi-system disorders, and in addition to the joints, you do have involvement of different organs like the skin, eyes, the heart, lungs, kidneys, etc. Increasingly, attention has been drawn to two facets, extra-articular facets of autoimmune rheumatic diseases, notably atherosclerotic cardiovascular disease, and second is the problem of bone health, osteoporosis in these group of disorders. And my brief this afternoon is to focus more on premature atherosclerosis in rheumatic diseases. This is the interface between cardiology and rheumatology. Over the last 10 years, there has been a remarkable paradigm shift in the way we view atherosclerosis. From an inert metabolic disease, we now believe that active immunoinflammation plays a key role in initiating, propagating, and activating the disease that is atherosclerosis, and it stands to reason that autoimmune rheumatic diseases, where inflammation is the key driver, provide a fertile soil for premature atherosclerosis. I would, in interest of time, focus on only two representative diseases. The first being rheumatoid arthritis, which in our country is perhaps the commonest inflammatory joint disease that we see. The second is lupus, which is a prototype connective tissue disease. And let's take a look at the problem of atherosclerosis in these illnesses. Now, what kills a patient in rheumatoid arthritis? Certainly not joint pains. Joint pains do cause untold misery. After all, it is the pains which bring the patient to the doctor. But if you look at causes of mortality, I would like to share with you this very recent publication, a large meta-analysis, 50 studies, close to 100,000 patients, with nearly 1/3 of the patients dying, and the most important cause was cardiovascular disease, accounting for nearly 40% of the deaths. So if you have 100 patients with rheumatoid arthritis, nearly 40% are going to die because of cardiovascular disease. What might be the other causes? Malignancies, infections, respiratory diseases, and renal causes. So one has to realize that despite the fact that joints account for substantial morbidity, it's not the joints which kill them, it's the heart which really accounts for the mortality. Now, if you look at the reasons for accelerated premature atherosclerosis in rheumatoid arthritis, several factors come into play. These include subclinical vasculitis, mediators of inflammation, traditional risk factors like dyslipidemia, then treatments. Everything comes with a price. Glucocorticoids, which come with a baggage of metabolic problems like hyperglycemia, hypertension, insulin resistance. Treatments like methotrexate cause hyperhomocystinemia, and the problems with nonsteroidals are rather well known, and all of these put together give rise to endothelial dysfunction and cardiovascular disease. The moot point which then arises is cardiovascular disease in patients with rheumatoid arthritis different? Are they any different in is the disease spectrum any different in patients who have cardiovascular disease without rheumatoid as compared to patients who have rheumatoid plus cardiovascular disease? Now, this is a slide which shows the cumulative incidence of coronary artery disease in patients with rheumatoid and patients who have de novo coronary artery disease, and I would like to draw your attention to this fact. If you look at unrecognized or silent myocardial infarctions, the number of silent events is much more in patients with rheumatoid arthritis. Yes, you do have angina and sudden death also much more in these patients, but what is important to realize is the coronary artery disease is more often than not silent. As students, we were taught that if you have silent coronary artery disease, think of diabetes, think of elderly individuals, and to which you can add rheumatoid arthritis, and the reasons are not far to see. Rheumatoid arthritis, first of all, physician awareness, afflicts women much more. This is traditionally a group where the index of suspicion of the physician, particularly in premenopausal women for coronary artery disease, is much less. So in this group, the physicians often ignore chest pain. Chest pain gets attributed to musculoskeletal causes. When you are paining all over, the physician tends to ignore chest pain. And finally, what happens is that because of arthritis, you have locomotor problems, you do not ambulate much, walk about much, and what you have is low cardiovascular demand because your ambulatory status is restricted. So angina may not occur till near occlusive coronary artery disease, and all these reasons put together account for the fact that coronary artery disease may often go unrecognized in patients with rheumatoid arthritis. The second important point for a clinician is that coronary artery disease is often advanced by the time you diagnose rheumatoid, and if you look at coronary angiograms, patients with rheumatoid are more likely to have a higher disease burden. They are more likely to have multi-vessel disease. So you have disease which comes early, you have disease which comes insidiously, is often silent, and you have a higher disease burden in patients with inflammatory rheumatic diseases. Then comes the last straw on the camel's back. All of us are used to diagnosing rheumatoid when you have accumulation of 4 out of the well-known 7 criteria proposed by the American College of Rheumatology. Now, criteria accrual takes time, and these criteria would actually get accumulated in a typical patient over a period of 7 years. But your risk for coronary artery disease begins even before you accumulate all criteria, and this is your cardiovascular risk threshold, suggesting thereby that this problem is not confined to patients who come late on in their disease course. Accelerated atherosclerosis starts early, even much before they accumulate the so-called 4 out of the 7 criteria. And to summarize, what you have in patients with rheumatoid is a greater risk of coronary artery disease, premature occurrence, traditional risk factors like hypertension, dyslipidemias by themselves do not account for the entire risk. You have new and novel factors. Endothelial dysfunction is a very important one, and this illness is silent. The disease burden is greater, and it comes on quite early in the disease course. Now we shift tracks. We've talked about rheumatoid. Let's take a look at lupus, which is the prototype autoimmune disease that we see, afflicts women much more. If you look at the causes of death in lupus, you have 2 peaks. You have early deaths and you have late deaths. And early deaths are more often than not due to active disease process per se, due to kidney involvement and infections. Very important in our country. And the second peak, if the patient survives the first few years, then start coming up the problems of atherosclerotic heart disease, and this was something which was recognized by Murray Urovitz and colleagues as far back as in 1976, and there has been subsequently a whole lot of publications underscoring this fact. If you look at causes of death in India, this is data from Christian Medical College, Vellore. 1-year survival, and this is data which is almost now more than 10 years old. 1-year survival about 90%, 10-year survival 60%, and renal disease, active disease, accounted for the vast majority of deaths. But this scenario is slowly but surely changing. As we have earlier detection, as we have better management, patients with lupus in our country are also living longer, and as they live longer, you are confronted with new problems other than the traditional infections, other than problems of chronic kidney disease, as we have better opportunities for renal replacement therapy, and what emerges is a problem of coronary artery disease in these patients. Again, like rheumatoid arthritis, multiple factors come into play in the pathogenesis. Some of these are well known, like you have with any other patient with coronary artery disease, like hypertension, diabetes, hyperlipidemias, but so also you have immunoinflammatory mechanisms which include immune complexes, aberrant T cell responses, antiphospholipid antibodies, homocysteine, and all of these contribute to promote vessel injury and accelerated atherosclerosis. Now, what we've talked about are inert facts. The fact is simple, that these patients die of accelerated atherosclerosis, but for a clinician, we need to graduate from inert facts to informed action. Why should a clinician bother about this? What prompted Dr. Chandra Shekar to have this topic about premature atherosclerosis in rheumatic diseases? The first and foremost is that these illnesses as a group are immunoinflammatory. Atherosclerosis has a very important component of immunoinflammation in addition to metabolic factors, as I showed you earlier. So it is logical that these illnesses provide a fertile soil for accelerated disease. And the second important thing is our ethnicity. Asian Indians are a peculiar metabolic group. Data from across the country has shown that we Indians have an adverse body fat distribution, and even normal weight Indians have adverse body fat deposition which predisposes to insulin resistance, greater proportion of metabolic syndrome, and we have a propensity to develop diabetes and coronary artery disease far in excess of Caucasians. If you have a 60 kilogram Caucasian and you compare him with a 60 kilogram Indian, the body fat deposition in Indians is going to be more adverse, insulin resistance is higher, and this stays with you no matter where you migrate in the world. So on one hand you have unfavorable ethnicity, on other hand you have immunoinflammation, and this spells double trouble, and which is why all clinicians who handle patients with rheumatic diseases need to know about this. Now, we also have an ostrich-like attitude. The first thing that we really say is denial, that all right, this is a problem of the West. What does data from our country suggest? And these are publications from my group. We looked at disease activity and lipids in rheumatoid. Same standard refrain. HDL levels were low, improved with better disease control. We went on to assess atherosclerosis in rheumatoid arthritis using carotid intimomedial thickness as a surrogate marker detected on ultrasound. Again, when you compared patients of rheumatoid with controls, CCIMT was increased. Then we went on to study lupus, and again using common carotid intimomedial thickness, the trend which emerged was that these young women, the average age in our cohort was 30 years, had higher carotid intimomedial thickness as compared to controls, and peripheral vascular disease as detected by Doppler was much more in Indian women with lupus. All in all, data from our group as also a couple of publications from SGPGI Lucknow suggest that dyslipidemia is common in rheumatoid and lupus. The good news is that with control of disease activity, the lipids tend to normalize. Early detection is possible if you pick up endothelial dysfunction. Carotid intimomedial thickness is a surrogate marker, and many patients exhibit subclinical atherosclerosis when your ECG would be normal, when your symptoms would not be there, and that is the time when you need to intervene. And finally, peripheral vascular disease too is a major problem. Now, how do you translate this into action? There is basically 5 things that you could do. First and foremost is physician awareness. Unless you are aware that you in a patient with rheumatic disease have to look beyond the joints, you can't do anything. Second is suppression of disease activity. Then primum non nocere, first do no harm. So the drugs that you employ have to be used judiciously. Then the concept of risk factors, and finally screening modalities, and I will take each one by one over the course of next about 5 minutes. Physician awareness. This is data from Canada, a country which is developed, and this is a stark story of the real state of affairs. A big clinic, 183 patients with lupus. Lipids had been obtained on only 1/3 of the patients. 2/3 of the patients, there were no lipid values obtained on clinic visits. 55%, half of these had dyslipidemia, but the case records charted a response in about 1/4 of these patients. So you can see this is a problem which is underappreciated, under-recognized, and under-treated. And I'm talking of a developed country. Then you look at Murray-Urovitz data again from Toronto. They have one of the largest cohorts of lupus. He looked at 2 time periods, 90 through 95 and 2000 to 2005. In this era, 90% of the hypertensive patients were receiving treatment. 5 years down the line, hypertension was recognized as an important comorbidity. Treatment was given in nearly all the patients. But if you looked at lipids, the same story, that only 1/4 of the patients, despite having documented hyperlipidemia, had received treatment. So obviously physician awareness is extremely important, and once you pick up something, you need to action that. The second is suppression of disease activity. Now, we've come a long way in the treatment of rheumatic diseases. Basic thing is we now treat early, we treat aggressively, we have newer drugs, and so far as the older drugs like methotrexate are concerned, we have newer ways of using them. We use them in a higher dosage, we use it parenterally, and more importantly, we are now response driven. Eminence, eloquence, experience have all given way to evidence. So what you do is you assess the patient, assess disease activity. It doesn't matter what tools you achieve to suppress disease activity, but you are governed by responses. In lupus we use a disease assessment score called SLEDAI, and in rheumatoid we use DAS28. I'll not go into the nitty-gritty, but if you have a disease which is still active, and you are talking not of subjective impressions but objective measurements, and if your disease is not controlled, you escalate your treatment, and once your disease is controlled, you are equally quick to de-escalate your treatment. So you have become response driven, and the end result is that the joints get better, the rheumatic manifestations get better, but so also the metabolic perturbations in rheumatic diseases. The third component for a physician is awareness of drugs. Corticosteroids are the fulcrum of treatment. Judicious use is needed, and we also perhaps need to revise our pharmacology knowledge. If you look at a clinical perspective, I would always divide anti-rheumatic drugs into 3 categories: drugs which are lipid detrimental, drugs which are lipid neutral, and some which are lipid beneficial. Now if you look at non-steroidals, problem of hypertension is well known. They are detrimental. Coxibs, that story is well known to everybody. Corticosteroids, multiple problems, salt and water retention, hypertension, dyslipidemia. So use minimum steroid dosages for the least possible time. Methotrexate causes rise in homocysteine, combine it with folic acid. Cyclosporin causes rise in lipids, you need to be very cautious. Azathioprine and sulfasalazine are possibly lipid neutral. They don't harm your lipids much, and hydroxychloroquine is something which is beneficial, has a lot of favorable metabolic effects, and an illness like lupus, unless you have very cogent reasons, all patients without exception, particularly lupus, should be offered hydroxychloroquine as a background illness. Now, how does a clinician sitting in the clinic decide which non-steroidal anti-inflammatory drug to use? I would focus only on one group of drugs because these are the ones that are commonly employed to tackle pain, inflammation, and this market is crowded. You have several companies breathing down your neck. How do you take a rational decision as to the drug which is to be used? The coccyx story is well known, ceaseless controversy, endless debate. Whether it is class specific, molecule specific, the debate continues. What you have is withdrawal of rofecoxib and valdecoxib, and in our country celecoxib as well as etoricoxib are available. On the bedside, you need to factor in three things. This is not a template etched on a tablet of stone, but these three things help you to decide which non-steroidal to use. And the three things are: is the patient at risk of GI events? Has the patient bled? And is the individual at risk of cardiovascular events? And if you factor these in, you get your answer. Young individuals, ankylosing spondylitis, no GI risk, no cardiovascular risk, you can use anything or everything. Actually doesn't matter, and you allow the patient the freedom to choose whatever NSAID gives maximum relief. Non-selective NSAIDs are as good as coxibs. Then you have patients, elderly, who have late onset rheumatoid, who may have cardiovascular risk, have no risk of ulcers, have no history of ulcer pain. They are on low dose aspirin. A preferred agent here would be naproxen. This is perhaps the non-steroidal which has the most favorable cardiovascular risk profile. A rational choice here would be naproxen. If you have GI risk in individuals who have bled, have ulcer pain, that's one setting where you would use coxibs. And if you have to use non-selective NSAID, you could use proton pump inhibitors also. Nowadays misoprostol is also available, but misoprostol is poorly tolerated by patients, and one would combine coxibs or non-selective NSAIDs in individuals who bled or have had ulcer pain but do not have any cardiac risk factors. And then if you have a setting where an individual has both cardiac risk factors, also GI risk factors, there one would use low dose aspirin, naproxen and a PPI. If one has to use coxibs, you would continue to use low dose aspirin and PPI, and this algorithm helps you to rationally choose an NSAID on the bedside. We move over to the fourth important thing, the interface of cardiology, rheumatology and endocrinology, risk factors, risk equivalents, and what to do about these. Now this is common knowledge. All of us know about traditional risk factors for coronary artery disease: male gender, smoking, hypertension, family history, cholesterols, and then we have CHD equivalents like diabetes, which confer a 10-year risk more than 20%. Now if you have a patient with rheumatic disease, you have to realize that the mere presence of rheumatoid arthritis and the mere presence of lupus in young women with a disease duration like 10 years is deemed as an additional risk factor. So you have to change your mindset and realize that the mere diagnosis of these illnesses confers an additional risk factor. And if you have lupus in a woman or a man more than 55 years or a lupus duration in excess of 10 years, it gets elevated to the status of a risk equivalent. And we physicians and rheumatologists have also to now embrace Framingham risk calculator despite its shortcomings, despite the fact that it may not be entirely applicable to Indians. This is a useful tool, and the buzzword is that the Framingham risk calculators under-calculates the risk of coronary artery disease in patients with rheumatoid and lupus. And finally, over the next 2 or 3 minutes, what should you do? And for this you need to triage your patients. If you have frank coronary artery disease or equivalent, you go over to intensive risk reduction. If you do not have frank coronary artery disease, you have the presence of risk factors. Just enumerate the number of risk factors. If these are minimal, routine risk reduction. If they are substantial, you calculate a 10-year coronary artery event risk using the Framingham risk calculator. Depending upon the risk, if it is more than 20%, you go on to intensive. If it is somewhere between 1 to 20, it is substantial. And this is what intensive, substantial and routine are. You need to be obsessional with your follow-up. Record blood pressure at every visit. With intensive, the target blood pressure would be 130/80. You can be a little more liberal with routine risk reduction. Aspirin use in intensive and substantial may be given a go-by in routine risk reduction, and similarly your cutoffs for LDL cholesterol become more stringent if your risk is higher and your monitoring interval becomes shorter. You need to follow up these patients very diligently, and of course commonsensical things like advising the patient to stop smoking, optimization of weight, minimum use of glucocorticoids, screening for hypothyroidism, and use of ACE inhibitors and ARBs as the first line antihypertensive agents is extremely important. Now, should you employ research tools like ultrasound for picking up CCIMT? Well, the data on this is not available. I, at this point of time, would not suggest that all patients should be subjected to this. We are a resource constrained country, and all guidelines should be extremely resource sensitive, and perhaps we need more data before we can employ it in a routine clinical setting. But other risk factors like hypertension, diabetes, lipid should be aggressively sought and treated. Chairpersons, ladies and gentlemen, I would like to end my presentation with what my good friend Professor Joy Phillips mentioned, tips. The take-home messages are simple. Cardiovascular risk is an important clinical problem. It's no longer in the realm of theory, it's actually a clinical reality. You need to screen your patients for lipids, hypertension, diabetes. If present, they need to be aggressively treated. Inflammation is the major driver. Tight disease control is important. If you control the underlying rheumatic disease, you are likely to have spin-offs which extend beyond the joints. Risk calculation in all patients.
Did you face problems in terms of high elevated liver enzymes, and how did you liver enzymes, and how did you tackle it?
Well, methotrexate is certainly known to be associated with elevation of liver enzymes. It's like your anti-tuberculous drugs. I don't know whether high dose is there. Actually, one thing that you need to realize is that in these patients might be useful to screen these individuals. Finally, you de-escalate your dose of methotrexate should you encounter aminotransferase elevation more than 2.5 to 3 times the normal. Many a time they settle down. Only if they remain persistently above normal limits, at that point of time you need to really rechange your strategy. And finally, India is in the epidemic of what is known as fatty liver. I think the gastroenterologists in the audience would bear me out that you do ultrasound, then you get fatty liver, which also contribute to aminotransferase elevation. I'm not too sure about the relative contribution of statins. Statins cause another problem, myalgias. So many patients are unable to take statins because of myalgias, but one has to realize that if you get aminotransferase elevation in a patient of methotrexate, don't put the blame at the doorstep of methotrexate immediately. It's an extremely useful drug which can be used for these patients. Retention rates, excess of 50% at the end of 5 years, economical. It's like the Maruti car. Look at other factors. In a small proportion, you have no choice but to withdraw methotrexate or reduce the dose if the aminotransferase elevation persists. Sir.
Please.
In a patient of rheumatoid arthritis, if he has got coronary artery disease also, and because his movements are restricted, the angina will not be evident. And so, we cannot subject him, I mean ECG may be normal and we cannot subject him for TMT. How to find out whether he has got coronary artery disease? Should we have to subject him to either conventional or CT angio?
Sir, good question. Now I am treading in the domain of a cardiologist, and I am not a cardiologist, but I'll tell you what the cardiologists at my institution do, and I stand to correction. They are not much impressed by CT angios. They would rather do a thallium, and if the patient cannot excise, they would rather do a pharmacologic stress using dobutamine and then do a thallium. No matter what people say, they are generally not happy looking at morphologic abnormalities on a CT angio. They are more happy doing a thallium 201 scan. Stress may be brought about by your usual treadmill when you do. If you have bad knees, as many people have, then they would give a pharmacologic stress. But let me tell you that this is something that where I would interact with my cardiology colleagues, and I would be happy if there are any cardiologists in the audience to get their thought process. But CT angio, no. They would rate thallium 201 scan as much better. Maybe Pinoy can add something, or other colleagues. That's what is usually done at AIMS.
As you know, all the rheumatic diseases have got their own remissions and exacerbations. Is there any during remissions? Is it more all these risk factors and is it related to the remissions or exacerbations? Any event, is it related, or do the remissions also provide some remission in your risk?
Actually, you see, what happens is that some of these things change with disease activity. If your disease activity goes up, your lipid levels go up. Once your disease activity is controlled, the lipids normalize. It is the cumulative burden, and now more and more people are talking that if you cannot have a 12-month remission, if 10 months you are able to have a better disease control, the area of under the curve of inflammation is much less, the spin-offs are better. Certainly, some things would change, but structural abnormalities like CCIMT, which happen over a period of time, if you look at a cross-sectional viewpoint, you can't comment. So it is inflammation over time which integrates into this.
Can you call it?
Again, this is a very difficult question to answer, because HSCRP is now employed by cardiologists as a screening, and immunoinflammatory diseases do have rise of acute phase reactants, whether it is ESR, whether it is C-reactive protein, whether